Welcome back to the channel. Today, I will be presenting on penetrating neck injuries, or PNI. These injuries are high-risk trauma scenarios that require prompt recognition and careful management to prevent life-threatening complications. A penetrating neck injury is defined as any trauma that breaches the platysma muscle of the neck. This distinction is crucial because injuries that do not penetrate the platysma are generally superficial and rarely life-threatening. Penetrating neck injuries can result from stab wounds, gunshot wounds, or accidental trauma, and they frequently involve critical structures such as major blood vessels, the airway, or the esophagus. Penetrating neck injuries are most commonly seen in young adults, particularly between the ages of 15 and 40, often as a result of assaults or motor vehicle collisions. Stab wounds are the most frequent cause, whereas gunshot wounds are less common, but typically more severe due to high-velocity injury and involvement of multiple structures. Mortality rates range from 3 to 10% for stab wounds and can be significantly higher for gunshot injuries. To understand these injuries, it is important to appreciate the anatomy of the neck. Clinically, the neck is divided into 3 zones. Zone 1 extends from the clavicles and sternum to the cricoid cartilage, and contains structures such as the subclavian vessels, the aortic arch, and the apex of the lungs. Zone 2 extends from the cricoid cartilage to the angle of the mandible, and contains the carotid artery, jugular vein, larynx, pharynx, and esophagus. Zone 3 extends from the angle of the mandible to the base of the skull, and includes the distal carotid artery, the pharynx, and cranial nerves 9 to 12. Zone 2 injuries are generally the easiest to surgically access, whereas zones 1 and 3 often require imaging prior to intervention due to their anatomical complexity. Patients with penetrating neck injuries may present with what are described as hard signs or soft signs. Hard signs indicate the need for immediate surgical exploration, and include active arterial bleeding, expanding hematoma, shock, pulsatile hematoma, air bubbling from the wound, massive hemoptysis or hematemesis, and airway compromise manifested as stridor or severe respiratory distress. Soft signs, on the other hand, may include minor bleeding, difficulty or pain when swallowing, a stable hematoma, or minor voice changes. Soft signs typically warrant further imaging if the patient is hemodynamically stable. The initial management of penetrating neck injuries follows the standard ABCDE approach. Airway assessment is paramount, particularly in the presence of stridor, hoarseness, dyspnea, or subcutaneous emphysema, and early endotracheal intubation is preferred. If intubation fails, a surgical airway such as a crocothyrotomy or tracheostomy may be necessary. Breathing should be assessed to rule out complications such as pneumothorax or hemothorax, particularly in Zone 1 injuries. Circulation must be stabilized by controlling hemorrhage with direct pressure or hemostatic dressings, and establishing intravenous access for fluid resuscitation or blood transfusion if shock is present. Disability assessment involves evaluating the patient's neurological status and cranial nerve function, especially for injuries in Zone 3. Finally, exposure requires a complete examination of the neck, chest, and upper thorax to identify additional injuries. In hemodynamically stable patients, investigations play a key role in guiding management. Computed tomography angiography, or CTA, is the first-line imaging modality for detecting vascular injuries. Plain radiographs or CT scans are useful for identifying fractures or foreign bodies. Esophagography or endoscopy may be indicated if esophageal injury is suspected, while bronchoscopy or laryngoscopy is warranted for suspected tracheal or laryngeal injury. Laboratory tests should include a complete blood count, type and cross-match for blood products, coagulation profile, and arterial blood gas if airway compromise is present. The definitive management of penetrating neck injuries depends on the patient's clinical presentation and the zone of injury. Patients with hard signs or those who are unstable require immediate surgical exploration. For stable patients with soft signs in Zone 2, imaging is performed first, and surgery is undertaken if significant injury is identified. Zone 1 and Zone 3 injuries, even if stable, generally require imaging prior to any surgical intervention. Surgical repair may involve vascular repair or ligation, primary repair of the trachea, esophagus, or larynx, and nerve repair if feasible. Potential complications of penetrating neck injuries include airway obstruction, massive hemorrhage or shock, infection including mediastinitis, nerve injury leading to vocal cord paralysis or dysphagia, esophageal leak, and stroke resulting from carotid artery injury. Early recognition and rapid intervention are essential to reduce both morbidity and mortality in these patients. To summarize the key points, Any injury that penetrates the platysma is potentially serious, whereas injuries that do not penetrate the platysma are usually minor. Hard signs of vascular or airway compromise require immediate surgical exploration, whereas soft signs in stable patients generally necessitate imaging first. Zone 2 is the most surgically accessible, while zones 1 and the 3rd of May require detailed imaging. Airway compromise is always the top priority, and high-risk injuries include those involving the carotid artery, jugular vein, trachea, or esophagus. That's all for this video. Thank you.